The number of women in the U.S. who die in childbirth is nearing the highest rate in a quarter century. A woman giving birth here is twice as likely to die than in Saudi Arabia and 3 times as likely than in the United Kingdom.
And this is happening in a country that spends more on health care than any other country in the world.
So that leaves the U.S. with the worst rate of maternal deaths in the developed world. The Centers for Disease Control says 60% of those deaths are preventable.
You need to know this. Texas has seen an unprecedented spike in the rate of pregnancy-related deaths.
Texas now has the highest maternal death rate, not only of any American state, but of anywhere in what is called the developed world.
We have an issue here in Texas. It was determined that we had a significant increase in the number of maternal deaths in Texas. So significant that Texas was being referred to as a third world country. It was very alarming, obviously. In 2013, Representative Wally from Houston actually passed legislation to create a maternal morbidity and mortality task force to look at what's going on here and what can we do to address it. That Dr. Ollier, who's the chairwoman of the task force, has pointed out that California has made a significant dent in their maternal morbidity and mortality, and one of the ways they did it was by having a very structured system of care, almost a checklist. I believe that we have lots of tools that we can use. It's always much easier said than done, but I know that this is something that the medical community is very concerned about and is interested in addressing. So I think if we can come up with some proposals out of this task force and work with the medical community, work with the healthcare providers, that we can actually implement some things that will make a difference. They have some big challenges, part of which we tried to address some in the session, and that was making sure that we had data that could actually be accessed. One of the things that they recognize is that we needed to change some of the checkoff boxes in death certificates that would more accurately reflect whether or not this was related to a pregnancy or not, which would give us obviously more specific data that could be useful.
We have data that showed that there was underreporting, especially until 2000, of maternal mortality, and because of that, the CDC and the National Vital Statistics Office introduced in 2003 a change, a revision to the death certificates when they included a checkbox, which basically was allowed to define if the person who died had been pregnant at the time of death, or pregnant within 6 weeks of death, or pregnant within 1 year. This change has resulted in increase of number of deaths being reported, approximately twice. Texas, it seems to be that the rate of maternal mortality was approximately steady between 2000 and 2010. However, something happened in 2010, and between 2011 and 12, we had a doubling of maternal mortality. And this is not something that had been observed in any other state. This kind of change is very unusual. Doubling, should not happen bar some natural disasters, wars, and this kind of events.
The maternal mortality rate in Texas did not double between 2010 and 2012 after all. That was the initial finding of a study published in Obstetrics and Gynecology in 2016. But a new study reevaluated maternal deaths in 2012 via different methods, along with record views. While the previous study placed the mortality rate at 148 deaths, new research linked just 56 of those deaths to pregnancy or birth. The issue may be connected to the 2003 federal decision to add a new checkbox to the U.S. standard death certificate. While the box indicates that a deceased woman was pregnant or recently gave birth, Medical Director Elliot Main says it's often checked in error. Because pregnancy-related deaths are so uncommon, the frequency of the box being checked in error can significantly impact the maternal mortality rate reported.
It was really interesting looking back at the data for maternal mortality. The first thing I would say is that it is shocking regardless that Texas, which is part of a very wealthy country and it's a wealthy state, that we have these problems. I think that was the first thing that when I looked at it, I was like, this is horrible, I can't believe this is happening. And then you look back at the data and you're like, okay, so how did they make these calculations? How do we find these statistics? So some of it has to do with how do we report statistics and vital statistics in the US and in Texas, and there's still some discrepancies about it. In terms of maternal mortality, from what I can tell, it's not just intrapartum. Intrapartum sometimes is the most obvious time when you see intervention from obstetrician, gynecologists. They actually take times between, pregnancy related within the first 42 days versus pregnancy associated, which is within the first year. And that all is counted in that calculation in terms of maternal mortality. And I think some of the studies that we've looked at say that some of those may have been misclassified. So maybe this might be inflated somewhat in terms of the actual numbers. However, still it's more than what it should be. We should, and looking back over some of those described incidences and looking at the Texas Maternal Mortality Task Force, we still see areas where we could be better. And part of it is that our safety net needs to be better. We need to be better about taking care of patients not just within the first 6 weeks after delivery, which is nothing if you think about the rest of that patient's life, and especially during that vulnerable first year. And shoring up our safety net, helping make sure patients and providers are educated about risk, and also, and I think also intervening in hospitals and making sure we're keeping up with best practices. We have to be extremely vigilant. We have to keep up with the data. We have to keep ourselves educated and to try to follow best practices, to do the best we can for our patients. There's no time you can really be nonchalant, and it's complex. There's a lot of complexities, because it's not only just an individual, but it's a systems problem, and so we have to work on that. Contribute to maternal mortality in Texas. The top 5 causes that were noted included cardiac events, drug overdoses, particularly opioids, hypertension and eclampsia, hemorrhage, sepsis, and then for 6 and 7 was homicide and suicide. I think that, we don't live in a bubble. We're not. It's hard though, because that's not as much our training. When we go to medical school, a lot of our training is in the, biochemical and physiological processes that cause disease. But I think that for us to forget that people live within the context of their environment and their societies and, their families and their relationships, if you neglect to look at that, you miss a lot of really important things. Or if you're just like, okay, I'm just going to focus on this thing, you have to see the patient in that larger context. One thing, I think that something else I'd like to say about the maternal mortality issues in Texas is that it is very hard to see that there are persistent ethnic and racial disparities in terms of maternal health, and also in terms of health in general, for patients of different racial backgrounds. And I think that that's an area where we have to not only educate physicians and providers, but also that is somewhere where we still need to invest more resources to help patients and to help try to minimize those disparities.
The task force did come up with some preliminary recommendations, number 1 of which was we need to do a better job of ensuring access to care. There were certainly some other things that were determined to be at play here, one of which was a disproportionate number of deaths among African American women relative to the number of births.
So my name is Dr. Roundtree, and we are here today because of the startling trends of maternal mortality among Black women. Some of the most startling statistics, specifically related to Black women, is that Black women only accounted for 11% of Texas births in 2011 and 2012, yet we accounted for 28% of pregnancy-related deaths. 28% of pregnancy-related deaths. So I say, if not now, when?
The data first came out in 2015 that Black women were dying, and became popularized, that Black women were dying in childbirth in the United States at 3 to 4 times the rate of white women, and that we were being, that the UN, the United Nations, called us to task for this, right? Like, there's a list of things the UN said. It said we had too much mass incarceration, our schools were still segregated, but when it came to health, and they said Black women are dying in childbirth, and you should be ashamed to do something about it, the United States of America. So this is really a global conversation that's centered around Black women. And so when the pushback we got was, oh, that's because Black women are so obese. Oh, that's because Black women make poor choices. Oh, that's because Black women are so old. We are not 4 times as obese. Let's be clear about that. I do my little crunchies, but we're not that obese. So when we look at the data, we disaggregate it by income and by weight, and it turns out that a Black woman who is normal weight still has a higher risk of death in childbirth than a white woman who's obese. So I can do all the questions I want. If you are still racist, I'm going to die. So at some point, we have to deal with the racism in this country.
If we were not talking about the most marginalized people, the most marginalized people would die, and nobody would even miss us. We cannot keep having these single issue movements. That don't take in my experience as a Black woman, because I don't live a single issue life. So that's why this is so important to me, and that's why being an organization in Texas, being a Black women-centered organization founded by Black women, directed by Black women, unapologetically serving Black women, it is important that we are at the front of this and not the back of this, and that we are leading this conversation and leading this work and leading this movement.
The fact of the matter is, if we deal with what's happening to Black women, all women get better. Just because it's not in your yard doesn't mean it ain't coming. It's the dog next door barking. If you really understood this data, white women they'd be running behind us. How can we help you? Because it's Black women, white women, way different than Hispanic women. We gotta stop this. We gotta stop it. It cannot be convenient for us to show up for each other. I need to matter to you when you're making chicken in your kitchen. Not just today. I need to matter to you when you're making decisions about how you're gonna spend your money. I need to matter to you when you go to the polls and voted for that asshole that we have in office. I need to matter. And if we don't change this, y'all are gonna be dying next. This is where we are.
I just don't see that there's any reason to do piecemeal things here. I don't see that there's any reason to continue to come up with different programs and have a woman go to this program at this point in her life and to this other program at this point in her life. It's great to have all these programs, and if in a perfect world all of those programs were synced somehow so that you could easily move from program to program, okay, but that's not the way it works. And so I think the best option, and what I would love to wave my magic wand to have happen, is that we would allow women of childbearing years to have continuous coverage on the same program so that there are no chances for gaps to occur.
If we could all take just a moment of silence for all of the families who have been forever impacted by the loss of a mother.